Hello friends, in this video we'll be talking about the pelvic organs part 1. Here we'll be talking about only the male reproductive organs, and in the part 2 we'll be talking about the female reproductive organs. So coming to the male reproductive organs, we have the prostate gland first. So coming to the location of prostate gland, we can see that it is located here, the prostate gland. Just beside here we have the rectovesical pouch, which is between the rectum and the seminal vesicle. And here we have other structures like retropubic space of Retzius or the cave of Retzius. This is the peritoneum lining the bladder and the urethra. And here is the urogenital diaphragm with the perineal body, and this is the fascia of Denonvillers. Here is the rectum, and here pelvic mesocolon also will be there. Along with that, the pubic symphysis, the median umbilical ligament, and the anterior abdominal wall. Coming to different lobes of the prostate gland. So 4 lobes are there: anterior, posterior, lateral, and this is lateral and medial. So I'll give you a small mnemonic to remember: PALM, palm. The palm lobes, palm, posterior, anterior, lateral, medial. And the openings also are very important. We have the prostatic urethra and the utricle. This is the opening for the ejaculatory duct. Now coming to the horizontal section or the cross section of the prostate gland, we have the outer false capsule, and this black color is the inner true capsule. Between that we have the prostatic venous plexus. This is just like the thyroid capsule, where you have outer false and inner true, but their plane of cleavage is present along with the thyroid veins. Here prostatic venous plexus is found. Now if we go little inner, we have the small prostatic buds, or I can call it the main prostatic glands, or prostatic buds. And then we have the submucosal and the mucosal glands. And here SCS. Alright, so 3 parts will be there. S, prostatic sinus, 2 will be there, and 1 C as in colliculus seminalis. And this is the prostatic urethra. Coming to the capsules of the prostate gland, as usual we have the outer false and the inner true capsule with the prostatic venous plexus. We have the rectal wall with the fascia. Coming to the blood supply of the prostate gland, arterial supply, we have the inferior vesicle, middle rectal and internal pudendal arteries. Now the venous drainage, we have 2 pathways for venous drainage: the prostatic venous plexus, then the internal iliac veins, and into the IVC as in inferior vena cava, which explains the tumor spread to the heart and lungs. And then another pathway into the vertebral venous plexus of Batson and the cavernous sinus, or you can call it intracranial dural venous sinus. Got it? So this explains the metastasis of the prostate cancer into the brain and the vertebral column. Now the lymphatic drainage, it drains into internal and external iliac along with the sacral lymph nodes. Now the nerve supply, so please remember the nerve supply, the parasympathetic part will be common to all the organs, that is the S2, S4. Got it? And the sympathetic only is going to vary. Here it is L1, L2 from the hypogastric plexus. Now coming to the applied anatomy, we have the benign prostatic hypertrophy, where the median lobe of the prostate is enlarged along with the sphincter vesicae muscle. And the most important feature will be the formation of post-prostatic pouch of stagnant urine, which makes the patient here to urinate more, to have the more urge to urinate. It occurs in patients who are older, who are like 50 years of age and above. and the levels of prostatic acid phosphatase or prostate specific antigen are checked. Now coming to the histology of prostate gland, the most important feature will be the amyloid bodies first. So this marked in 2 here is the amyloid bodies. The one marked here, we have marked as 1, that those are the irregular folds called as the columnar epithelium, or I call it the follicles lined by columnar epithelium, and all over we can find a number of connective tissue. So see here, there is so much of connective tissue here. This is the histology. Alright, now let us go to seminal vesicle. So the seminal vesicle is a small dilated sac or a pouch which extends from the ejaculatory duct. This is important for storage of the sperm, and also it contains a fluid called as vesiculose that has fructose, some enzymes and choline. Choline anyway we know it is a nitrogen base. Right, so this is the seminal vesicle, and here the histology, we have the columnar epithelium here also, or I would say the mucosal folds. Yeah, the mucosal folds over here. And then we can see the muscle layer, marked number 2. And marked number 3 is the adventitia. Now coming to the vas deferens. We can see the course traced here, the vas deferens. This is the lower pole of the testis, from that the vas deferens is coming. Then it goes below the urethra, then the pubic symphysis upwards, then into the inguinal canal, then through the inferior epigastric artery, then through the ureter. So one site of constriction in the ureter, and then it enters the ejaculatory duct and then terminates into the opening of the urethra. This is the course of the vas deferens. Now the arterial supply, it is supplied by the artery to the vas deferens derived from superior and inferior vesicle with the middle rectal arteries. And the venous supply is from the prostatic venous plexus. Now coming to the histology. The histology of vas deferens, very similar to ureter. One difference is important here. Ureter has transitional epithelium. Here it is pseudo-stratified columnar epithelium. And we have the lamina propria here and the muscle layer. This marked in 3. That A, B, C, that is totally muscle layer. So we'll have inner longitudinal, outer circular, middle circular and outer longitudinal layer, and the fourth layer is the adventitia. So these are some of the layers. Now the vasectomy. So to end the male reproductive system, we have the vasectomy. So it is a surgical procedure where the vas deferens is cut and tied, which is very important for family planning in males. Anyway, in the gynec we discussed the details regarding the family planning. And this technique is poorly reversible, especially those who are very aged and those who are very young. This technique can be reversible and high chances of recovery if the patient is very young. And this has to be done only 7 years after vasectomy. This is important. Only 7 years after the procedure. So that brings us to the end of the male reproductive system. So thank you so much. I will see you in the next video.